Thanks everybody for joining us today. Good afternoon. My name is Melissa DeMars and I'm a behavioral health specialist with OPEN, the Overdose Prevention Engagement Network. And welcome to today's webinar, Understanding Alcohol Use Disorder and Treatment Options. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CEU, and McBath credit for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. Excuse me. Again, my name is Melissa. I'm a behavioral health specialist with OPEN, the Overdose Prevention Engagement Network, and will be moderating the webinar today. The Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain, and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBath credits, and for prescribers, all of our credits also qualify for the DEA-required substance use disorder training. We provide medication for opioid use disorder training for physicians, and this year we're incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. Excuse me. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We also provide overdose rescue support. We fund implementation of naloxone vending machine and distribution boxes. We also provide naloxone administration trainings, and these trainings are offered as live, virtual, or free online training courses. No planners, faculty, and others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. Excuse me. I'm happy to introduce our presenter for today. Anne Fernandez is a licensed clinical psychologist and associate professor in the Department of Psychiatry. She is also the director of clinical research for Michigan Innovations in Addiction Care through Research and Education. Her areas of expertise include substance use and health psychology. Her current research focuses on surgical optimization for patients with alcohol use disorders, alcohol use disorder treatment in the context of liver disease, and contingency management treatment for co-occurring alcohol and opioid use disorder. She leads or co-leads 5 grants funded by the National Institute of Alcohol Abuse and Alcoholism. Dr. Fernandez received her doctoral degree in clinical psychology from University of Rhode Island with a focus in health psychology. She completed her clinical psychology residency in behavioral medicine at Yale New Haven Hospital and her postdoctoral fellowship at the Center for Alcohol and Addiction Studies at Brown University.
Okay, well, thank you so much for the introduction and for those of you joining. I'm looking forward to talking to you about alcohol use disorder and treatment options. This is a topic I'm very passionate about through research, but also clinical work. I see patients at the Outpatient Addiction Treatment Service Center, and also had for a number of years worked in an alcohol-associated liver disease clinic where I saw patients who had alcohol contributing to their liver disease. So what I'm hoping that you learn today is more about alcohol use disorder, the definition and diagnostic criteria. I'm going to share information about alcohol use and alcohol use disorder population prevalence and how it's changed over time, highlight some at-risk populations and specific health risks, and share some best practices for screening, brief intervention, and treatment for alcohol use disorder and for unhealthy alcohol use. So to jump right in, alcohol use disorder, as a general definition, is a medical condition characterized by an impaired ability to stop or control alcohol use despite adverse social, occupational, and/or health consequences. It encompasses conditions that some people refer to as alcohol abuse, alcohol dependence, alcohol addiction, and a colloquial term that some use, alcoholism, which is stigmatizing for some, but I find for others is empowering. So I use that term only with people who indicate that that's their preferred term. So in this talk, I'll use the term alcohol use disorder. And for those of you who are not regularly screening and diagnosing this condition, alcohol and any other substance use disorders using current criteria in the United States are diagnosed based on 11 symptoms. The symptoms include withdrawal if alcohol use is stopped, tolerance and needing more of alcohol to get the same effect, increasing quantity and frequency of use over time, inability to control use, spending time obtaining, recovering, or using alcohol, giving up other activities, or always engaging in activities that involve alcohol, and continued use despite medical or psychological conditions that would suggest or would benefit from stopping. Recurrent difficulties to fulfill role obligations in life due to alcohol use, recurrent use in hazardous situations, that could be driving, that could be risky sexual situations, craving or strong desire to use or consume alcohol, and continued use despite interpersonal challenges. And so what this now we diagnose, and it's been a number of years that we've been doing this, but while alcohol use, that alcoholism term where there was a binary, you either had the condition or you did not, we now see and understand, and data and clinical care clearly indicate this, but it's more a spectrum of a condition that can progress over time. So initially, a mild alcohol use disorder would be defined as meeting 2 to 3 of those symptoms that I just read. Moderate use would be 4 to 5, and severe would be 6+ symptoms. And who diagnoses, I don't know why I'm having trouble with that word right now. This condition is generally going to be a licensed medical, psychological, or social work professional who's trained in mental health and addiction. And I bring that up because typically a person who's not trained is not always going to know how to do the full alcohol use disorder diagnostic workup. And often that requires a referral to a specialist to get a really detailed and accurate diagnosis. However, in settings where someone does want to do a diagnosis but maybe doesn't have the full training, I wanted to share this tool, which is available widely online. It's called the Alcohol Symptom Checklist, and it basically turns the 11 alcohol use disorder symptom criteria into a checklist of the symptoms, and a person can just check them yes or no. So this is something that actually can be more easily implemented in a clinic or a community setting where alcohol use disorder professionals aren't available. And in terms of epidemiology and populations at risk, I just wanted to share some of the data of trends in alcohol use over time. So this graph stretches from the 70s all the way to 2023. Most of the data I'll present today kind of stops in 2023 because that's really what's been published thus far. All the 2024 data is still basically being analyzed and hasn't been shared yet. But what you can see here is that while there was a peak in alcohol use in our nation in the early 80s, it decreased for a number of years and then started to increase, particularly in the period just around when COVID happened, actually. So if we look closer at this little piece here, you can see kind of after, it was starting a little bit, but especially around 2020, there was a big jump in alcohol use. The Midwest is the orange region that we're in. And then you can see it increase through 2021, and then 2022, suddenly things started to go down. And there's some indication that that continued into 2024 as well. So there may be some kind of inflection point that's taking place right now, but we'll have to look at data over time to see what may happen with this data. One kind of sad thing to share is that one of the big studies that annually studies this, the NISDA, is part of SAMHSA, and that whole office was just riffed. So I'm not sure what's going to happen with some of our epidemiological data, unfortunately, moving forward due to some changes in administration priorities. But we do know from the 2023 NISDA survey, National Survey for Drug Use and Health, that in 2023, almost 30 million Americans, which is just over 10% of the population, met criteria for an alcohol use disorder in the past year. So this is a really large number of people in our country. There's some indication that was a slight reduction from 2022, where NISDA found sorry, I said 30 million before, so it was 29 million, and the year before it was around 30 million. One of the best studies of alcohol use disorder epidemiology actually only takes place once every decade. That's the National Epidemiological Survey for Alcohol-Related Conditions, or the NESARC. And you can see for the decades for which data is available, there's been an increasing trend in alcohol use disorder and also other alcohol unhealthy drinking or binge drinking criteria, and was going up until 2012 and 13. They actually just completed the next wave of surveys, but they're not yet published. So if this is something you're curious and interested about, if you kind of continue to look or go to presentations about alcohol use, there will be some new data reflecting what the current trends are that I'm very curious to see. And when we think about alcohol use disorder in our nation, this is not a disorder that is equally distributed across the population. There are definitely certain age groups, sex, and race and ethnicity groups, as well as major regional differences in alcohol use. And a very long and persistent difference has been that men tend to have alcohol use disorder at a higher rate than women, though I'm going to show you some data that suggests that that's actually going to change with the younger generation. So over time, alcohol use in women has been increasing. The most recent data is showing 58% of alcohol use disorder cases in America are men and 42% are women. And when we look across race and ethnicity, so for a very long time, white Americans, non-Hispanic, have been one of the leading groups that drank and had alcohol use disorder at the highest rate. Native American populations, Alaska Native, are another group that historically has had a high rate of alcohol use disorder, with Black and Hispanic lower and Asian Americans the lowest. And so I mentioned that some of this is changing. So for the first time in potentially history of tracking alcohol use at a population level, women in just the 18 to 25-year-old age group for the first time have exceeded men in binge drinking. So if you look at this graph, this was basically like pre-pandemic data to after the pandemic. there's actually been a big drop in alcohol use in young adult, like adolescent to young adults, which is very significant because as cohorts age, some of these heavier drinking cohorts are aging out, and the younger adults now are drinking less than those who are alive at older age groups. So there could be a major shift in demographic and epidemiological data in alcohol use that could also bring in a number of reductions in alcohol-related deaths and other conditions, which would be positive news, but remains to be seen. As you can see, there was some reduction in use in those 26 to 49, but not as dramatic. And then in older adults, the changes aren't as noticeable. Although one thing that there's sort of a trend, but this is not a significant trend, that older women in this over 65 age group actually increased drinking a little bit post-pandemic, which is also a concern and a trend nationwide, that this increase in alcohol use in women is taking place across a number of age groups. And there's a reason that we should be particularly concerned about women and health risks from alcohol use. So research consistently shows there's an accelerated progression among women from when they start drinking to when they develop alcohol use disorder and have their first potential treatment admission. And if you look at the grams of alcohol a person consumes, there's a higher relative risk of alcohol-related disease and injury per gram of alcohol women consume compared to men. This has sometimes actually been called telescoping. It's a widely known thing that happens. And telescoping, the term basically meaning taking something that is normally very far away and making it bigger and closer. So it just brings those consequences closer in time and more severe for women compared to men. And women are also more susceptible in general to alcohol-related organ damage and cancer. So a big finding that's been publicized quite a bit is the high link between breast cancer and alcohol use that is getting to be more well known, but is probably not well known even maybe to many people on this webinar. And so if we want to understand why this is, I think the thing that stands out to the most people is that women are smaller, they have smaller body sizes than men, which is true, and so that's part of it. But even if you matched a man and a woman with the same exact BMI and age, a woman would get drunker faster on the same amount of alcohol. And there's a number of reasons that happens. One of them is actually the amount of water in a person's body. So women have less water in their body relative to men. And so alcohol gets less diluted. They also have less of an enzyme called alcohol dehydrogenase in their metabolism, their gut metabolism, so stomach and intestines, allowing more alcohol to reach the blood and therefore the organs. So a higher level of concentration actually impacts the organs. There's also hormonal differences, and age has a big impact. So as people age, men and women, they will get drunker faster on the same amount of alcohol that they had when they were 22, let's say. Maybe some of you have noticed this. If you're, over 40, I've noticed it even as a 44-year-old woman. So this does happen over time. And what is considered low risk or high risk drinking in a population also varies for that reason by biological sex and by age. So generally in America, the recommendation for alcohol use, which is now seen to be actually somewhat outdated to the recent data, which shows risk at lower levels of drinking than we previously realized. But regardless, what's published now in the United States is that women should not have more than 1 drink a day on average, and men should not have more than 2, and weekly no more than 7 for a woman and no more than 14 for a man. There's a movement to try to reduce that to no more than 7 or no more than 1 a day for everyone. But that has not happened yet. And Canada has changed their recommendations. If you're curious, you can look it up. They're much lower than ours. So there's some scientific disagreement. Alcohol lobbying groups are also very highly involved in trying to keep these from being further reduced. So it's a fun Google if you're interested in learning more. So another thing that's important to consider in the nation is deaths from alcohol. So alcohol is actually one of the top causes of preventable death in the United States. And so I'll talk about alcohol-related deaths in two ways. There are deaths from alcohol where alcohol is the direct contributor to the death, so alcohol causes the death. And then there's another statistic that has to do with whether alcohol contributed to the death, but it might have multiple contributors. So this graph shows alcohol-caused deaths. So the numbers are a little lower than some others, but essentially you can see this trend over time, similar to that alcohol consumption graph that I had showed you, where alcohol-related deaths have climbed with alcohol use in our nation. Particularly, you see that big spike around the time of the pandemic, and then a downturn post-pandemic, which will hopefully continue in the coming years. And then again, here's this narrow definition when we're talking about alcohol cause deaths, that alcohol was the cause. So we see that 51 or so thousand, which is a little higher than the number for suicides, but less than the causes directly by opioids. But when we expand that definition to include any death that has an alcohol attributable factor, so like some cancers, for example, and other causes of death, maybe alcohol and other drugs were involved in an overdose, etc. Alcohol is actually a higher contributor to death than opioids and suicide. And I think this is something that gets a little bit lost when we talk about deaths and overdose in our country, is that people don't fully comprehend that the number of people who die from alcohol use, either directly or indirectly, is much higher than opioids, and something that is a public health crisis just as much as the opioid crisis. But when we look at deaths across race and ethnicity, there's a very disproportionately high number of deaths in American Indian and Alaskan Native communities. So I did point out earlier that the use in those communities is also high relative to other groups. However, the death rate is extremely disproportionately high, which reflects other socioeconomic factors and risk factors and disparities in access to treatment, etc. And the group with the highest death rate is those 45 to 64. Interestingly, though, because causes of death in younger adults is low, and alcohol is the number one cause of preventable deaths in very young adults, which is pretty striking if you think about it. It's more likely in males and also in rural versus more urban populations. And the number one cause of death from alcohol and alcohol use disorder is liver disease, and that number keeps growing. The alcohol liver disease numbers in America have really increased. I'm going to show a little bit of data on that, and then followed by alcohol poisoning. And if you're curious where Michigan kind of sits in some of these alcohol use disorder and death rates, we're kind of in the middle, actually, like right in the average, very like purple state of us. We kind of hit that mean in a lot of different ways. And alcohol is one of them. Even Wisconsin has quite a higher rate of alcohol use than us, which isn't that far away. The Northeast also has a high rate of use, and the West Coast. And then the South and Utah is extremely low, and the South is also lower than us. So I mentioned, we talked a little bit about the pandemic and alcohol use, but one of the really striking things that happened during that time was actually this huge spike in alcohol-associated liver disease deaths that increased through 2021 and then decreased a bit in 2022 and was very high on the West Coast. As I mentioned, alcohol use is among the highest in the country, and but overall it happened across the entire country. And I wanted to make sure to take a little bit of time to highlight some information about the adolescent and young adult alcohol use patterns, because it's going to foreshadow some of the trends in the country. So over years, heavy alcohol use in 12 to 20-year-olds has dropped. So you can see from 2014 onward, it keeps getting lower. Even the pandemic did not have that big spike in alcohol use in adolescent and young adult populations. It actually decreased through the pandemic. And this graph shows over time the percentage of young adults 18 to 25 binge drinking. And you can see that across the early 2000s, there's been a reduction in binge drinking, but particularly in men. So this blue graph up here, blue line of the graph up here shows that in men, binge drinking within this study from RTI, which is a group that is an independent agency that studies some of these trends, reduced from 50% to 28% of males in that age group reporting binge drinking, while women were kind of flat, then increased a little bit, but then also went down. But you see again that flip-flop between the men and the women's drinking patterns that's taking place for the first time in history. And the reasons for that are numerous and really interesting. And some of it's, I think, unknown, but probably has a lot to do with cannabis use, actually. So increasing cannabis use in young adults. So cannabis use is now kind of replacing alcohol. Also related to less socializing. So people spend a lot less time they spend more time at home, essentially. So because of COVID, because we have so much virtual ability to work, to connect, to talk, people are having less social interactions. And you can see that actually in adolescent and young adult sexual behavior. There's been a big decrease in and later onset of sexual activity because people actually are spending less time together. And cannabis use has increased. So women's roles in society have also changed. And if you have noticed, I used to have some fascinating slides in another talk about the marketing towards women and alcohol. And once you start thinking about it, you will see it everywhere. So lots of those funny memes that's like mommy wine time, and little cartoons and comics and all kinds of stuff that's out in there that women have really taken alcohol use, kind of embraced it in some ways, partially due to marketing, partially due to culture shifts as a way to relieve stress, as something really normal among women and moms. And that was not the case nearly as much 10, 20, 30 years ago. So it's a real shifting culture and acceptance around women's drinking. So kind of female equality, but one that maybe isn't as healthy. I'll share some treatment approaches with you for alcohol use and alcohol use disorder. So one of the really important things to share about alcohol use disorder treatment in general and substance use disorder treatment more globally is that the really most important takeaway I want people to know from this is that most people don't get treatment. And so anyone who's on this call and is wanting to learn more about alcohol use disorder treatment or is doing it, or maybe works in a setting where there's a chance to screen or intervene or talk to people about it, anything that you can do to get a conversation about alcohol use, recommendations to reduce drinking is maybe the only time that that's ever going to happen for that person, because so few people are referred or self-refer to formal alcohol use disorder treatment. That basically the message is anywhere and in any health context that we can get this to people, we should do it, because that's maybe the best they're ever going to get. And so it's about 8% of Americans that got any AUD treatment in the past year who had an AUD. And when we're talking about medications for alcohol use disorder, it's even less. It's about 2% of people with an alcohol use disorder who received any medication for AUD. And then changing, so essentially when we think about alcohol use disorder treatment, obviously I think the place our mind goes the most is to the individual level. but I really like this graph because it shows the levels of intervention that we can actually have for alcohol problems and alcohol use disorder in a society, and actually the impact. So one-on-one alcohol treatment is obviously extremely important and the thing that we need to be doing. But there's a lot of things on a broader level that can have a really big impact on these epidemiological trends that I presented. So most interventions or research is at the individual level, looking at the types of treatment that we give people. But if we kind of move out, we can think more about how do we integrate care for alcohol use disorder in other settings. Melissa mentioned in my introduction, some of the work that I do is trying to get alcohol use disorder into alcohol-associated liver disease clinics or in surgical settings, because so few people get this treatment in specialty care. We have to find new ways to get it to people. Primary care has been a big setting of integration for behavioral health and addiction for this reason, because a lot of people go to their primary care doctor, not as many go seek out alcohol treatment. There's also lots of public health efforts that are needed. And actually, one of the biggest impact things that can happen is policy change. So things like alcohol taxes, minimum purchasing, minimum age restrictions, and insurance coverage for treatment. These are all things that actually drive those alcohol numbers. It's really about access policy and how much access people have and the cost, and the attitudes and opinions people have about alcohol and other substances that drive these epidemiological numbers. So policy changes have a huge, huge impact. And people often say underage drinking, or like setting a minimum drinking age, just makes younger people want to drink more. There might be some truth to that on a individual level, but on a population level, setting a minimum drinking age has a huge impact on reducing access and use in underage populations. And you can see that when you compare across countries. So what can you do at the individual level in your clinics or places that you work? So depending on the type of setting, if it's actually a mental health or addiction treatment facility, or if you're in a primary care or some other community setting, is going to impact what you can really do. So I'll kind of put this into a little bit of several phases and levels of intervention that you can implement. So the first and really important thing is we don't know if someone is drinking or if they have an alcohol use disorder unless we're doing screening. And then for those who are drinking at harmful or unhealthy levels, there are lots of brief intervention approaches. And you can also start to address alcohol use disorder even with brief interventions. Although for those who do have alcohol use disorder, ideally you provide a referral for them to a specialty care center, or if you're able to do it in the setting you work in, you provide that care or work to get medications or psychotherapies into the hands of the person who needs it. So one of the screening tools, in addition to the alcohol symptom checklist that I mentioned, if you're in a clinic where you're not a specialty addiction clinic and you want to get a sense of whether people are drinking at risky levels, one of the tools that I recommend is called the Audit C. This is used annually in the VA and in many primary care settings. And it has 3 questions about how often a person drinks, so the frequency, how much they drink, so the quantity, and then how often they binge drink, essentially. And those are all scored from 0 to 4, so a maximum score of 12 on this measure and a minimum of 0. And typically, depending on the application of the tool, often there's a cutoff of 3 for risky drinking for women and 4 for men. And so that would indicate some kind of intervention or conversation, with higher numbers more likely to indicate an alcohol use disorder. And it's actually, this is something that I've worked on in my research and in talks, that is actually extremely important to use a validated tool and not just ask a clinically seemingly intelligent question about alcohol use. So when doctors or other healthcare professionals that aren't in addiction specifically ask about alcohol use, they tend to ask in a way that doesn't get the most accurate information. And that's not because they're not trying hard or that they're not experienced. It's just something that's shown up in study after study. So in this particular study, they looked at hepatologists, which alcohol liver disease is the #1 cause of liver disease. So you would hope these docs would be pretty good at alcohol assessment. But what they found is actually they do a worse job than the audit C. And the audit C does almost as well as an addiction trained specialist. So these tools can be really effective in detecting alcohol problems with just 3 questions and doesn't take that much longer than a trained, general provider asking questions. So that's just a plug for using structured and standard validated measures in your clinic because it can be really helpful. So if you're in a clinical setting where you want to get additional information about alcohol use, so not just self-report, people can sometimes be motivated to conceal alcohol use. This is particularly the case. As I mentioned, I worked in liver care and in transplant during my internship. So when people have a transplant on the line for a liver, let's say, and their alcohol use can potentially make them not be eligible for that liver, people can be very motivated to conceal. And also in other settings, people don't want to admit, they don't want to talk about it. There are times when that does happen, although a lot of people will report honestly to healthcare professionals if the questions are asked in the right way. But with that aside, there are biomarkers to detect alcohol use. So these aren't going to detect alcohol use disorder. This is just going to detect use. The one that the most people know about is the ethyl gluc, which is a urine test that can detect alcohol use in the previous 3 to 5 days. The sensitivity and specificity is fairly good, but it definitely does have false positives and false negatives. So something to be taken with a grain of salt. If you do this test and a person disagrees, that they might be telling the truth because the test is not perfect. An actual better test that isn't as widely used is called phosphatidylethanol, or PEth for short. And this is something through University of Michigan you can actually order. It's a standard lab and it's a blood test. And this is a newer test and looks at excuse me, blood lipids to detect alcohol use. So they last a lot longer. It can be 2 to 3 weeks, but also up to 4 weeks of alcohol use. It's extremely accurate in its sensitivity. And so it's a better test and more accurate test in many ways than ethyl gluc. So that's a useful test to have and to use if it's available in your health system. Well, if you're in Michigan Medicine, it is available. So I'm going to talk a bit about brief intervention and referral. So many of you have maybe heard of SBIRT, screening, brief intervention, and referral to treatment. So it's a preventative service like blood pressure or cholesterol screening, where when patients have standard care at various clinics, it can help identify individuals who are drinking above recommended amounts. So the first step is basically you do a screening like the audit C or the audit, which is a slightly longer version. And then based on those cutoffs, you have a short conversation with patients who are drinking above recommended amounts and refer to treatment when appropriate. I'm not going to go too into detail about what this works or the techniques, but know that there are many, many manuals published in the world. So the World Health Organization, the US SAMHSA has quite a few. Basically, you can find them very quickly with instructions and advice on how to do this. Really briefly, what they generally recommend is to give brief advice with longer intervention options if needed. And just a few pointers if you are doing this, whether you read the manuals or not, is you want to essentially do that screening and then you want to share with the person what your conclusions and recommendations are clearly. So for example, based on this test, you scored a 4. We know that for women that indicates some unhealthy alcohol use. I'd like to talk to you a little bit more about that. What we recommend for a person is reducing use to this level or to abstain, especially if the person has some kind of is pregnant or has liver disease or any other conditions that make alcohol more risky. You want to gauge motivation to change and tailor discussion accordingly. So you don't want to just drive home and pummel the point that someone has to stop drinking if they're clearly telling you that they're absolutely not going to do that. You can try to move their psychological readiness along before they make actually those changes. If appropriate, provide education, make a plan with the person and provide referrals, and then repeatedly do this when you see a patient. So one of the things that happens with alcohol use compared to smoking and other health behaviors is that people will sometimes not follow up as well. So they might talk about it once or not at all. But alcohol use, just like any other chronic health condition like diabetes, is chronic and it can have a relapsing course as well. So it's not a one and done kind of thing. It's the type of thing you want to keep checking in with people about. And I just wanted to highlight about being really specific and clear with how you communicate. So with alcohol, for some reason, more so with smoking in our society, when people have done studies of clinician behavior, when they have these discussions with patients, is that when people talk about alcohol, they have kind of vague and unclear recommendations like, oh, maybe you're getting yourself into trouble, and then laughing and saying you should really be careful about your drinking. Where with smoking, they'll say you should quit, your wife should quit too. Why don't you bring your whole household in? I'd like to see you put some structures into place. So the tone of the conversations often ends up being very different depending on the health behavior that people are talking about. And I bring this up so you can notice if you do have these conversations, if your own type of whatever internal bias or normalization of drinking that maybe you have yourself maybe comes into play when you're having these conversations, and just kind of recall and remind yourself like, hey, it's okay, I can make recommendations. I can state my conclusions and have a clear and honest, open conversation about alcohol, just like I do with other substances or health behaviors. And people often respond differently when you have that kind of bearing to how you speak about it, like open and kind, but also straightforward. So that's kind of more the brief intervention or something that you could do in most health settings where alcohol may come up, whether that's surgery, whether that's your primary care, whether that's a liver clinic. But in some cases, you're going to have more professionals, or you're going to want to make referrals to have someone get an intensive treatment. So really broad overview that I like to point out is when we talk about alcohol treatment, we're talking about several different dimensions. And I think that they get kind of mixed in together. And so what I want to point out just as a first step is that there's the type of treatment, but there's also the level of care. So level of care refers to the intensity of the treatment. And the intensity of the treatment increases often with the intensity and complexity of the alcohol use disorder, as well as maybe the co-occurring medical conditions and the person's motivation. So this little pyramid on the left shows that the substance use disorder or alcohol use disorder is the smallest percentage of the population, but the most severe form of the disorder. And below that is actually people who don't have an alcohol use or substance use disorder, but they're drinking at an unhealthy level. And so as you get up towards that top of that pyramid, the intensity of the treatment should also increase if the person is willing and able to take part in it. So the lower and less intensive intervention is going to be the brief intervention that we just talked about, having a discussion, giving advice, following up with the person. And then we get into more outpatient settings. So a person comes to a group weekly, or they see a therapist weekly. And then there is something called intensive outpatient programs. And those are for alcohol or other substances where you go into a group setting, usually 3 days a week for a half day. So it's 9 to 12, Monday, Wednesday, Friday is what we have at our clinic, for example. And it's a much more intensive dose of therapy. There's also short-term inpatient, like day programs. And then, of course, there's residential rehabilitation programs that can last from 2 weeks to a month to 90 days to sometimes a year as a much more intensive option. And usually the inpatient is most important for people who need environmental restrictions. So it's often almost over-recommended, so not everyone needs it. If someone can manage their alcohol use in an outpatient treatment setting and they don't need complete environmental control, then many people can actually do that, but not everyone. So it's important to assess that and understand that when you're making those referrals. So then I mentioned this idea, there's levels of care, but then there's type of treatment. And then type of treatment can be broken into two really broad categories, which is psychotherapy or talk therapy, and medications. And alcohol use disorder has both. So psychotherapy can also include and be given in an individual setting. It can be done in a group setting. It can be done by a peer even. There's a lot more peer involvement, like people from other 12-step communities maybe come into clinics, or people with some lived experience. And there's case management. And there's different types of psychotherapies. I don't have the time it's not the appropriate talk to go into all of them, but I just want to point out that there's this concept of empirically supported therapy, which is essentially research supported. And my messaging around this is really that there are best practices in terms of psychotherapies for alcohol use disorder and addiction, but there is no best practice. So usually when research studies compare different therapies, they find that any therapy that follows a theoretical orientation and has a structure and has key elements will work. And it tends to not be that one is always clearly better than the other. So things that have been research supported, just to give a list, this is not an exhausted list, is cognitive behavioral therapy, 12-step facilitation, which is essentially working with a therapist who helps you get connected with 12-step and what works you through that. Motivational enhancement therapy, mindfulness-based relapse prevention, dialectical behavioral therapy, or skills, acceptance and commitment therapy, and the CRAFT approach, which is a family kind of more systems-based approach. But there's many more. And I think one thing when you think about psychotherapy is actually not so much like I have to find the perfect therapy, because in honesty, you might not find it in a given city or state anyway, but it's really kind of about what the person that you're working with is willing to do and what might fit. Like some people really have tried 12-step, they really don't like it, then trying to force them into that is probably going to be a square peg round hole situation, but they might be willing to try something else. So that's kind of the more important dimension to consider as opposed to like nailing the type of therapy. There's 3 FDA-approved medications for alcohol use disorders and several others that can be used off-label. The 3 that are studied and recommended for AUD specifically are naltrexone, acamprosate, and disulfiram. Naltrexone is also used for opioid use, so you may also know of it in that context, and it can help with cravings, urges, and also diminish the pleasurable effect of alcohol if people do drink when they're taking it. And it's a pretty low risk medication with some little bit of liver toxicity, but research has shown actually that it's actually pretty safe in a lot of cases. So yeah, so thank you for listening. And yeah, Melissa, I think is going to moderate any questions, and I'm happy to kind of jump in and answer anything that you might have. One note is that I'm a psychologist PhD, not an MD. So there might be some questions if they come through that I can give you my best PhD take on it, but you might want to confirm with a medical provider, given that's not my background.
Thanks so much, Anne. We really appreciate this insightful presentation, and thank you for your time and expertise. Before we move on to questions, if you can just notice on the screen the continuing education credit information. You can scan the QR code by using your camera option on your phone, or click on the links below the QR codes to access information about obtaining credits. This will also be emailed out to all attendees after the webinar. Okay, so the first question that came in, what age can a minor be considered for medications for addiction treatment? I have a minor who is 16 years old and has been coming to the ER since around age 14 with a high BAC of about 2.236 to 0.260. He is speaking without any signs of intoxication. CPS has been notified, although mother has also sought out treatment. He's also diagnosed under fetal alcohol syndrome. Any suggestions?
Yeah, I mean, in terms of the medication, again, that's one of those things where I'm like, I'm not an MD, so I can tell you that like naltrexone, that's the one that's most prescribed in my experience, and often is the more effective. There's also an injectable. But if the person is underage, I believe that the parental consent is going to be needed for that. And I actually don't know the age cutoffs for the efficacy safety research. So that's something that if you're in an ED, if there's a psychiatrist or another professional addiction medicine consult or anything like that, they could give you that information more readily than I could, for sure. And there's also, I mean, as MOpen, as Melissa shared, MOpen has these amazing resources where you can literally just call that phone number and probably ask that question. And they are MD oriented answers and medication, very medication knowledgeable.
Yes, I was gonna put a quick plug in. Thank you, Anne.
Yeah.
Perfect case to send a consult in for, and we can put the link in the chat. But on our website page under program, you'll see clinician to clinician consultation services, and one of our providers would be more than happy to provide some patient specific guidance.
Yeah. I think some of my colleagues are like, they're really excellent physicians who staff that too. So you can get a great answer.
Thank you. Next question. I would love a recommendation for training related to learning about the various MAT options for alcohol use. Do you know where this could be found?
I think MOpen MOpen is like the place to get this. So I think it looks like Sarah's already putting stuff in the chat. So I think that honestly, like MOpen and some of the resources at University of Michigan are among some of the best in the country. So I think that some of those links, as well as these like regular webinars and different things. There's also, so UMAT's, the University of Michigan Addiction Treatment Service. We also do some trainings, lunch and learns, but also some community facing events. I'm trying to think. Sometimes they're also disseminated through MOpen, actually, if you're on emails, or any University of Michigan listservs, they do get disseminated when we have them, and we do some that are on medications. But I think MOpen is probably the most readily available.
Yep, so our consultation link is in the chat. Sarah also posted our alcohol use disorder educational guide, so please check those out. We have a question. I would love help with a close family member. I never know how to start the conversation without being offensive, but I want to be firm.
Yeah. So I can give very like general advice, I can't give specific advice because of like licensing and all of that stuff, but I can give general advice for a hypothetical situation. I think that is a extremely, extremely challenging thing to deal with. So just first of all, that's very hard. And often dynamics and relationships make it really difficult to do that because, you know, I'm sure as you experience that you have a lot of strong feelings, that person probably has a strong feelings, then you have your whole other relationship that has nothing to do with that substance, and they all get really mixed in when you try to do this with family members. But what I would recommend is, one thing is you can get advice and professional advice on that if you wanted to. There's actually a family group through our clinic that sees family members if needed. There's also Al-Anon and some other programs, although Al-Anon takes a little more of like a hands-off approach to some of it. But my general recommendation for people is that similar to what I had shared about how to approach conversations with patients in clinics, is trying to approach it in a very straightforward manner. And while emotions can run really high, to try to share information as like a loving and concerned person with a planned conversation, not one that happens in the heat of the moment. Like, let's say a person's intoxicated and you're angry or sad or upset, and then all of it comes out. It's better to try to plan a conversation at a time when both parties are in a better headspace to have that conversation, and approach it in as best as you can, a straightforward manner where you're sharing. And sometimes you can there's something called Dear Man. If you want to Google it, it's actually a dialectical behavior therapy approach to how to have a sort of straightforward and assertive communication, which basically describes the problem. Like, hey, I've noticed, I'm just going to make stuff up, I've noticed more and more beer bottles in the recycling. The emotion, the D, the E, the emotion, I'm feeling I'm feeling a little concerned. I'm worried about you. I love you a lot. And I know this is really hard to talk about, but I just feel like I need to talk to you. And then the A is, what are you asking or what do you want? But to be clear with that in your head, hey, I really want you to think about treatment. Hey, I really think you should consider stopping. Or or if you're drawing a stronger line, whatever that is, but be clear in your head going into it. And then the R is actually reinforce. So reinforce is, this is going to, what's in it for the person? Like, I think this could bring us closer together. I think that this would be really good for the kids, or whatever it is. Like, what's the hook? So not just I'm telling you to do this, but what's the pull? There's pull and push in recovery. So what's the pull? What's the benefit to that person? I know that's like a super quick, overview, but kind of thinking through it in that way can be really helpful. And there's a lot of good books, and I'm trying to remember off the top of my head, and I'm not thinking of it. I can try to send it to Melissa after. There's another really good book that is an approach to talking about this with loved ones that's very couched in like a positive reinforcement model. So like setting limits, but also doing it with love and not just kind of abandoning the issue. That has a really nice balance to it that I'll look it up after I get off this and send to Melissa, and maybe she can distribute it, or you could try to like get your email through and we could try to get it to you too.
Thanks so much, Anne. I think we're really close to time. I don't think we have time for any more questions, but I just want to say thank you again for being with us today and for this very informative webinar. And I hope everybody has a good rest of the day.